Thank you very much. I am grateful to the APSA board, to the members, to Dr. O'Neill, and to everybody who contributed to my being here. I am indeed very humbled and very honored. I'm going to give be giving a brief account of the state of the pediatric surgery in the East African region, the challenges we encounter, and how we are trying to mitigate and go about solving these issues. The East African region is an area with common geopolitical and socioeconomic landscape. In fact, there's a political and civic push towards integration, just like you'd see in the European Union. The East African region comprises of 5 countries, namely Kenya, Uganda, Rwanda, Burundi, and Tanzania. And though there are 2 other countries, South Sudan, which is to the north of Kenya, and Somalia, which is to the east, towards the east coast of East Africa. Though these 2 countries are not technically speaking part of East Africa, they influence the architecture of East Africa to such a point that they deserve mention. The total population of this area is about 148 million people, and that does not include 10 million people each from Sudan and from Somalia. The area is represented, would be equivalent to what you would see in the United States according to the atlas, in the states marked in asterisks to the southern border of the United States. Health resource allocation has not been a priority from earlier decades, but this is slowly changing. This is evidenced by accessible and free maternal health care, as well as free health care to the children under the age of 5. And also there is a agitation towards improved quality of care to everyone, every other person involved. These improvements will obviously take time to realize, and it is because we are battling with a history of cumulative neglect in the health sector. The evidence is clear, and surgery as a discipline has not been spared. We have one of the fewest distribution of not only pediatric surgeons, but general surgeons in the world. And that is evidenced by, for example, you can see the ratio between the US and COSEXA surgeons is 500 to 1. COSEXA stands for the College of Surgeons of East, Central, and Southern Africa. This recently, Egypt has been included, and as you can see from the atlas, it is the area shaded in green and represents about 1/3 of the landmass of Kenya, of Africa. The situation is even more dire when you look at pediatric surgery, to be specific. You do appreciate the discrepancy between the numbers in the US and East Africa. This might have changed slightly because from our institution and from various other institutions which have recently emerged, there are some attendings who have recently qualified. Just to look at it from another angle, on this slide, the lower map represents what would be a normal world map, and the skewed one above it represents the current distribution of health workers worldwide based on expenditure. You do appreciate that Africa shrinks significantly. More relevant to us is the children. The infant mortality rate in Kenya stands at 42.9 per 1,000. To bring this into context, the infant mortality in the US is about 6.94 per 100,000. That means that for every 100,000 children, 7 children in East Africa have to die for one to die in the United States. And more importantly is that 20% of these are surgically preventable, meaning that 10 out of the 42.9 would be saved by the presence of a pediatric surgeon or some form of pediatric surgical intervention. There are also elements which bring a twist or make us a unique region. Obviously, this is not unique to East Africa. This is within the context of Africa. Poverty is at 50%, and that means that 30 million children are predisposed to and are at this vulnerable group. HIV prevalence is 1 in every 8. That is 6.1% of the total population. This, by the way, is an improvement to what it was a decade ago when it stood at it's currently at 1 in every 16, and a decade ago it stood at 1 in every 8. The literacy level is also a factor to consider. With the literacy level in East Africa is averagely around 60 to 70, about 73%, it's been said. And there is country to country variation. For example, Rwanda has a literacy rate of below 60%, whilst Kenya has a literacy rate of 80 to 85%. The infrastructure has not been spared either. There are also deficits in this sector. The photographs illustrate part of the solutions that we are trying to come up with. The rejuvenation towards building the new infrastructure. The diagrams illustrate a 190-bed capacity pediatric wing that is coming up in Kijabe Hospital in Kenya. It's bigger than the hospital, and so we like to call it a hospital within a hospital. There's other elements also, that is the impact of the regional conflict. As you may or may not know, some of Kenya's neighbors are plagued with protracted internal conflicts. South Sudan and Somalia. South Sudan has been in conflict for over 40 years. They are currently experiencing relative stability. Somalia has been in conflict for above 20 years, for above 2 decades. This has impacted on us because we have two, the largest and the 3rd largest refugee camps in the world. Dadaab, marked in asterisks to the eastern border of Kenya, represents the largest with a population of about 350,000 people. And Kakuma, to the north, which receives influx of refugees from South Sudan, has a population of about 125,000 people. We get a lot of, these two camps account for, distance-wise would be about 1,000 kilometers from our hospital. And they would account for 1/3 of our surgical pediatric patients. There is a collaboration we have between us and the UNHCR, the United Nations High Commission for Refugees, to try and bring in these patients. This involves, there's issues with accessibility because it takes about, though it is 1,000 kilometers, it takes about 2 to 4 days for them to access healthcare, specialist healthcare. The other issue is that Dadaab is currently on restricted movement because of security concerns. There is clearly no shortcut. We cannot import specialists. It is not sustainable for the long term. The need has been known for a long time, and the effort is towards training now. The conversation has moved from crisis management to long-term solutions. So far, there are 3 institutions in Kenya, in East Africa. The Bethany Kids AIC Kijabe Hospital is the oldest amongst the 3, 9 years old to be exact. It was founded by Dr. Dan Panaru amongst other colleagues. The University of Nairobi has recently begun a program which started in 2013, and the Mulago Hospital also began a program last year. There are many, as you know, a program will need many supporters. These are some of the organizations that we are working tirelessly with to make sure that the child is healthier and that there is a training for the African pediatric surgeons for a sustainable future. Even as we move forward to try and solve our internal issues, definitely we need help. One is that we have not built enough capacity. We don't have enough trainers to keep training people who will then carry on with this future. So we need trainers, and therefore I would thank Dr. Diane Farmer for emphasizing on global surgery. The other support services would be pediatricians, dietitians, pediatric nurses, and anybody who is interested in making the child live a healthier and a happier life. I would like to acknowledge some of the faces who are in the photos, some of whom are members of this organization. Dr. Dan Panaru is the founder member, and Eric Hansen is the current program director, of whom I'll be joining him in September, from beginning of September as an attending. The others are Dr. Skip Neblit, who's visited us, Mike Skinner, Mike Matlack, last but not least, Dr. Jim O'Neill. Thank you.